Good evening. Good afternoon, sorry. Good afternoon. I thank Dr. GVK as well as organizing team for providing me the opportunity. And also thank the chair, my professor Dr. Dharmaraj, and the co-chair for a wonderful introduction about me. My talk of the day is how you are going to care the elderly in terms of controlling the BP. As I thank Dr. Kannan for giving good platforms, what is elderly, how they differ from the younger populations, and what aspects you have to take into consideration whenever you design a treatment, maybe a diabetes oriented, maybe hypertension oriented, because the effect is also important. At the same time, you also give paramount importance for the side effect of the medications which they cannot tolerate. So achieving a goal without inducing any harm for the individual is having a paramount importance whenever you design a treatment for elderly. So let us focus how we are going to take care of the hypertensions. Now this is the phase of life, it will go in Bhasha, it clearly shows. The 7th and 8th phase of the life is for us to relax. So these are the people who are going marching above 65 years of age, and that is a place where you want to relax in your life. But this is the place where you are going to get all sorts of illness, maybe hypertension, maybe a diabetic, or maybe dyslipidemia, and all neurological parameters, elevation of decline in EGFR, kidney disease, heart disease, so much of things comes to your life. This is the part. So we have to design our management in such a way the patient has to prolong his life without any comorbidities, and the quality of life has not be compromised. So we know that hypertension is the most leading cause for death, which is highly modifiable. Nearly 1.8 million people are harboring hypertension across the globe, and out of which, in other way around, 1 in 5 adults is having hypertension. Nearly approximately 50% of the people doesn't know they have hypertension. Even treated people are only less than 50% of the people are diagnosed being treated. This is the reason for having a large chunk of hypertension, that is uncontrolled hypertension, is common in world. And this criteria is based upon when you keep the cutoff of systolic BP more than 140. Now, after the SPRINT trial, ACC has clearly downgraded the systolic parameters. They push the boundaries down. They keep, whenever the BP crosses more than 130, we have to label the patient as hypertension. So what happens when you lower the boundary of systolic hypertension to 130, you can see nearly more than 70 to 80% of the people above the age of 55 years falls into one of the categories of hypertension. So these amount of things you have to understand. The SPRINT trial is one of the well-designed trial where even elderly populations more than 85 years, they push to the target of 120. They want to analyze what happens in nearly of 3 to 4 years. They found that the CVD risk is phenomenally lower in the elderly population, super citizen, even if you target BP of 120 and 80, because we have a good number of molecules in our armamentarium of management of hypertension. And India, as like diabetes, India also has the rank holder of hypertension. And how we differ from the Western Caucasian group is we have yearly onset. As like diabetes, we have a yearly onset of hypertension. And there is a large urban-rural divide is there. And ICMR in-depth study has clearly shown the food intake with the rural and urban is, we consumes more amount of junk-related activities, more fatty, more food rich of salt and fat. And multiple CV risk factors are there. So we are thin fat individuals, we are more dyslipidemic, we are hypertension, pre-diabetes, and more of things is very, very common in Indians because they share a common cell hypothesis. And the rising population, the age of the population is also another factor for high prevalence of hypertension in India. And low awareness, even if you give a medicine, BP medicines, if the BP comes normal, they will stop the medicines. They think that it's like a fever. So whenever you treat fever, when the fever goes out of my body, I have to stop the medications. Like that, they are thinking that when the BP comes down, when the BP touches a target of 120/80, without the knowledge or without the guidance of the physicians, they will stop the medication. They land up in one form of any cardiovascular events. And we see many number of people with proteinuria. We see large number of LVH because of uncontrolled hypertension. So what is the importance of BP in terms of cardiovascular? This graph clearly shows as the systolic BP rises, it crosses more than 160, the mortality of CV events is very high, and the systolic BP is having a much more importance than that of diastolic BP in terms of CV reductions. So I am not here to say don't control diastolic hypertension, it also have an importance, but the systolic BP, the paramount importance is if you curtail, if you reduce the surge of systolic BP, you can reduce the CV events in the future. And this is the normal phenomenon. Even I will go through this cycle. So as age advances, the systolic BP is going to increase, irrespective of the male or the female. But once you touches the 60 years, the diastolic BP starts to dip. That is the reason we have got a wide pulse pressure. So many of the elderly populations comes to your clinic, we record the BP even touched 60. That is the reason they say, I checked my BP at my home, my BP was 60, so I stopped the medicines. They may say things that what may be reasons for stopping the medications. The systolic BP, there is no dip in the systolic BP. It, as the age progresses, it increases. But as age advances, there is a drop in systolic BP. This phenomenon has to be understood. That is the reason we commonly see isolated systolic hypertension in elderly population than people with younger diabetes, younger hypertension. So what is the reason for essential or primary hypertension is all depending upon the vascular tree. That is exaggeration of age dependent stiffening process. Like hose pipe, the aorta is changed to PVC pipe legs. That is in any X-ray they will get atheromatous aorta. There is a stiffening of aorta. These may be the reasons for this. So whenever the percussion wave, tidal wave generated in the ascending aorta submerged together, that is the reason you are getting high systolic BP than compared to the fall in diastolic BP. And there is also excess collagen deposit around the tree, around the aorta, and reduced elastin. This is the things you can see. This is a complaint. Whenever the systole pump and the left ventricle pumps blend to the aorta, there is a stretching factor there. So the volume expands. Automatically the pressure drops. The diastole it shrinks. So this is mainly based of elastin. So when this high deposit of collagen and reduced elastin, automatically the compliance becomes very, very poor in elderly population. That is the reason the problem of systolic and the percussion and tidal wave joins together to produce high peak. So this is nutshell difference. What might be the difference? The young hypertension, the hormonal cause is the main reason. Here the mechanical cause, mainly because of the arterial stiffness is there. That is the reason for having high systolic BP compared to diastolic BP. So why I want to treat hypertension? Let it be the number. Why I want to treat? Many of the people say, I'm here for 60 years, 70 years. Why you want to treat? My BP is acceptable. So if you reduce the BP, systolic BP or diastolic BP, you can reduce the heart failure by 50%. You can also reduce stroke by 45% and MI by 25%. So what are the threshold where I have to keep for the patients? So different guidelines says different things. So one thing you understand, more than 160, you know the systolic BP 160, the CV risk increases. So all the guidelines says this is a stage 1, stage 2, stage 3. So only problem is after sprint trial, ACC and AHS clearly showed even more than 130, it has to be treated. They wanted to stages are stage 1, but European Society and NICE doesn't recommend. So even when it crosses 140 only, it becomes a paramount importance. Still that we can keep lifestyle modifications. You can ask the patients for some adopting like a pre-diabetic stage. You can ask go for a lifestyle changes when the patient is having overweight. Ask the patient to lose weight and reduce the salt intake and all. So single BP, don't treat the patient with single BP treating until it's 180, 100. Like that patient comes with a systolic BP of more than 180. So you check if it becomes falls in the hypersensitive emergency category, then you have to treat. So don't go by single value because single value can have much more. So 1 or 2 recordings is most important. And white coat hypertension you have to rule out. And also ECG showing LVH. The urine shows proteinuria. After excluding other causes, patient BP is normal. Go for repeated BP monitoring. These patients may be harbor masked hypertension. So in your clinic, BP may be normal. Outside your home, outside the workplace, the BP may be high. That can be reflected in the ECG in the form of LVH, or you see your fundus photography may shows hypertensive changes. So whenever patients comes to your clinic, my BP is normal, my BP is normal. So exclude other cause for LVH, exclude other cause for microalbuminuria. Check the fundus photography for any hypertensive changes. So everything comes to line, you can go for the BP. And recording BP also, because many of the times nurses or paramedical staffs are recording the BP. This is the param because which is in turn Hutchison itself. You ask you don't do immediately when the patient comes to your consultations. Give some sort of free times. Sitting position is allowed, and arm bar is supported. You have to give the support bar. There are many trials shows even not proper support can elevate the BP and all. And appropriate risk of appropriate things and the foot should be rested on the floor. These are the things has to be conditions. And the screening you have to done at least 2 mean recording has to be taken into consideration whenever you want to start medications. Adults more than 40 years, you can recommend the patients for annual screening of BP control. So what is the ambulatory BP control? So patients have any discrepancy between a reviewer BP recording and their findings, you have to go for ambulatory BP monitoring. 2 things we can do is one is home monitoring of BP, another is ambulatory BP monitoring. So ambulatory BP monitoring requires devices which has to be fitted with the patient that record every 15 minutes. They record the BP as like continuous glucose monitoring device. Home monitoring can ask the patients for a morning BP and evening BP. So and apart from clinic measurements, this home monitoring and ambulatory BP monitoring correlate much with the CV outcomes. So when you check the BP, 1 BP or 2 BP recording at the house or the clinical visit cannot be extrapolated for the CV event reductions. By doing a home monitoring BP, doing ambulatory BP monitoring, if you optimize the control, the CV benefit is phenomenally very, very high. But it requires sophisticated instruments, costlier, which is very all the patients in our country cannot afford for that. But home monitoring is somewhat of beneficial, falls in between the clinical measurements and home monitoring BP. It also have a relevance to that of CV events reductions, but it cannot detect the dippers. So nocturnal dippers cannot be detected by home monitoring BP. That can be detected by ambulatory BP monitoring. So any patients comes with BP of what I have to do. So when the BP is more than 180 or systolic BP 180, that patient's contacts emergency, needs hospitalizations and needs evaluation for the patients. If the patient is less than 180, also I will check whether the patient is having a diabetic or not. Any other CV risk factors there. If there is, check the another BP recording and put the patient on this as a guidance directed therapy. Many of the diabetic patients, if the creatinine is very good, we opt for AC inhibitor or ARB depending upon the kidney status. If the patient is non-diabetic, you can check either ambulatory BP monitoring or automated BP monitoring. You can check the BP. If there are patients affordable to do ambulatory BP monitoring or home monitoring of BP, the persistent BP elevations of more than 140 for clinical measurements. If his ambulatory BP monitoring is 130, please understand, ambulatory BP causes more than 130, it does a surrogate marker, the patient has to be put on medications. So clinic BP measurements is more than 140, we have to start the patients on, but exclude white coat hypertension. Please give importance for history, patient any occult heart disease is there or not. Patients having occult heart disease, we may put on beta blocker. Many of the things guidelines says don't put beta blocker in nutshell first line. But patient having angina, exertional angina, patient having one other form of ischemic equivalent, patients are far benefited with beta blockers than going for hunting other group of medication. So give importance for history. Patients any focusing on cardiovascular exophthalmosis, proptosis may give a clue for hypothyroidism, where you have to control the hypothyroidism than going for medications. And laboratory infections, routine investigation is mandatory. Sophisticated interventions is warranted when there is need. Don't push all the patients for echocardiogram. Don't push all the patients for carotid ultrasound, renal artery. Since you are suspect as a clinical background, if there is indications, you can go for the individuals. And apart from BP, check the patients with any harboring other side effects. Maybe hypertension coexisting with diabetes, hypertension coexisting with COPD, hypertension coexisting with any other form of vascular disease. Check for that and categorize which risk is falling. Patients falling high risk or very high risk categories, you have to categorize the patients. And this is the treatment goals. You can see I asked the stage 2, stage 3. When the more than 160, it warrants the medication. So no other arguments. But if you want to follow ESC, it is very easy for us. So when the patient crosses more than 140, if the risk is very low, we can give a lifestyle modifications alone. If the patient is diabetic and hypertension, BP is not 140, you have to put the patient on medications. So lean individual, BP is only one BP is there, no other CV risk factor, no family history of CAD or something else. You can put the patient as low risk. You can give a oral diet control alone as a therapy. Patients having diabetes, hypertension, patients with microalbuminuria, LVH, you put the patient on medications. So ESC is little bit easier for us to follow in a day-to-day practice. So treatment guidelines, in more than 65 years, whether you 65 years, when to initiate medications, whether the patient having diabetes, CKD, CAD, when the systolic BP crosses more than 140, the patient requires medications. But elderly patients more than 180, if the BP crosses more than 160, the medications can be started. This is the difference between ESC. When more than 65 years, 140 is the criteria. And more than 80 years, 160 is the criteria to start medications. Whether the patient is having stroke or it is easy to for us to. So what is the cutoff for hypertension and diabetes? What is the cutoff for hypertension and CAD? Don't get worried about all. So more than 140 for elderly patients, more than super seniors, more than octogenarian, go for 160 and all, and cutoff is the reason. And ESC guidelines clearly states any fit patients give the medications. They clearly say class 1 indication. Even age of 80 years, if the more than 160, please give medications as a class 1 indications. And patients of more than 65 years, if the BP crosses more than 140 is a class 1 indications. So class ESC clearly says more than 80 years old, more than 160, start the patient on class 1. More than 65 years, more than 140, class 1 indications. And please, is a class 2B. Any antihypertensive, even a frail older patients, if they are able to tolerate, give the medications. Even frail older patients, the class 2B indication. Check the functional capacity as told by condenser. So you check the functional capacity, how is the dementia level, how the other organs you are going to support. When you start medications, you can go for class B. And withdrawal of BP based on age or age of more than 80 years is not recommended. So 85 years, high BP, put the patient on. So don't say your age is very high, I will not treat. It's a class 3B, is a harmful effect when you don't do it. So lifestyle medications is a much more paramount importance. So dietary actions and physical activity, you can't ask the elderly patient to go for physical activity. The patient should be focused on dietary management, because adopting diet alone, there's a fall of 14 millimeter of mercury. So none of the drugs will give. And dietary sodium restrictions, depending upon the diuretic therapy, depending upon the coexisting history of blood, you can avoid heart failure status, kidney status, you can recommend the salt intake. So drug therapy, when there's less than 150 elderly patients, start a single drug. With the more than 160, you can start combination therapy, what we are doing for a longer duration. So we have a telma with amlodipine, telma with chlorothalidone. We have many combinations. Now the EAC is also endorsing our views. The crosses more than 160, you can start 2 medications in a single pill. So either start diuretic or calcium channel blockers for the individuals. If the renal angle is very good, if there is a proteinuria, if there is LVH, you can go for ACE inhibitors plus diuretic or ACE inhibitors and calcium channel blood depending upon the profile of the patients. And even triple drug combination in a single pill is also adopted, what we are recommending, what we are doing now. Telmisartan, amlodipine, chlorothalidone, telmisartan, amlodipine, hydrochloric acids, what you are giving. So elderly patients, depending upon the patient's profile, you can start our diuretic or calcium channel blockers. If the kidney is very good, the kidneys and when there is any microalbuminuria, when there is no evidence for hyperkalemia, there is LVH, you can go adopt ACE inhibitor ARB and check for resistant hypertension. If 3 drugs is out of 1 is diuretic is not having control, you can use beta blocker when there is any evidence of heart disease. Don't neglect to use a beta blocker. Patient having prostate hypertrophy, you can augment your prozosine, like that group of drugs as armamentary management. This is a nutshell, is very complicated. Any heart failure, any patient with hypertension with heart disease, put the patient on beta blocker. Any patient with stroke events, put the patient on CCB. Any patient with hypertension with renal problems, put the patient on ACE inhibitor or ARB for that matters. So target guidelines, irrespective of the age, is very easy. Keep the target less than 130 if the patient is able to tolerate, or keep to less than 140 if the patient is not able to tolerate the medications. So target less than 130 if is able to tolerate. If not tolerate, keep less than 140, and you can use any medications depending upon the patient's profile, comorbidities and all. Thank you for the patient listening.